Let's start. First of all, good morning to all of you. Let's start Sunday morning with our first aid reading. The last session we read till okay, we ended after Cushing syndrome. Let's start with next topic, Nelson syndrome, enlargement of pre-existing adrenocorticotropic hormone secreting pituitary adenoma after bilateral adrenalectomy for refractory Cushing disease. Increased adrenocorticotropic hormone, hyperpigmentation, mass effect, headache, bitemporal hemianopia. Treatment is transpenoidal resection, post-operative pituitary irradiation for residual tumor. Okay, we understood the Nelson syndrome. Let's move on to next, adrenal insufficiency, inability of adrenal gland to generate enough glucocorticoid plus or minus mineralocorticoid for body's needs, can be acute or chronic. Symptoms include weakness, fatigue, orthostatic hypotension, muscle ache, weight loss, GI disturbances, sugar and or salt cravings. Treatment include glucocorticoids plus or minus mineralocorticoid replacement. Yes, we understand this. Next, primary adrenal insufficiency, decrease gland function, decrease cortisol, aldosterone, leads to hypotension, hyponatremic volume contraction, hyperkalemia, metabolic acidosis, skin mucosal hyperpigmentation shown in the image A, increased melanin synthesis due to melanocyte stimulating hormone, a byproduct of POMC cleavage, primary pigments, the skin/mucosa. Addison disease, chronic primary adrenal insufficiency caused by adrenal atrophy or destruction, most commonly due to autoimmune adrenalitis, high income countries, or TB in low income countries. Okay, next, secondary and tertiary adrenal insufficiency, decrease pituitary adrenocorticotropic hormone secretion, secondary decrease hypothalamic corticotropin release hormone secretion, tertiary no hyperkalemia, aldosterone synthesis preserved due to functioning of adrenal gland, intact RAS, renin, angiotensin, aldosterone system, no hyperpigmentation. Secondary adrenal insufficiency is due to pituitary pathogenesis, tertiary adrenal insufficiency is most commonly due to abrupt cessation of chronic glucocorticoid therapy, HPA suppression. Tertiary form treatment. Okay. Next, acute adrenal insufficiency, also called adrenal Addisonian adrenal crisis, often precipitated by acute stressors that increase glucocorticoid requirements, that is infection in patients with pre-existing adrenal insufficiency or in glucocorticoid therapy may present with acute abdominal pain, nausea, vomiting, altered mental status, shock, Waterhouse Friderichsen syndrome, bilateral adrenal hemorrhage in the setting of sepsis, that is meningococcemia, leads to acute primary adrenal insufficiency. Concerns for adrenal insufficiency: check AM cortisol or ACTS stimulation, decrease AM cortisol and or decrease peak cortisol on stimulation test, measures random serum ACTH, decrease or inappropriately normal ACTH, secondary or tertiary adrenal insufficiency, increased ACTH, increased adrenal efficiency. Okay. Next, hyperaldosteronism. Increased secretion of aldosterone from adrenal gland. Clinical features include hypertension, decreased or normal potassium, metabolic alkalosis. Primary hyperaldosteronism does not directly cause edema due to aldosterone escape mechanism. However, certain secondary causes of hyperaldosteronism, that is heart failure, impair the aldosterone escape mechanism, leading to worsening of edema. Primary aldosteronism does not directly cause edema due to aldosterone escape mechanism. However, secondary cause of hyperaldosteronism, that is heart failure, impair the aldosterone escape mechanism, leading to worsening of edema. Okay. Primary hyperaldosteronism seen in patients with bilateral adrenal hyperplasia or adrenal adenoma, Cone syndrome. Increased aldosterone, decreased renin leads to treatment resistant hypertension. Secondary hyperaldosteronism seen in patients with renovascular hypertension, juxtaglomerular cell tumor, that is renin producing, and edema, cirrhosis, heart failure, nephrotic syndrome. Okay. Next, neuroendocrine tumor. Heterogeneous group of neoplasms originating from neuroendocrine cells which have traits similar to nerve cells and hormone producing cells. Most neoplasms occur in GI system, that is carcinoid gastrinoma, pancreas insulinoma, glucagonoma, and lung small cell carcinoma. Also in thyroid medullary carcinoma and adrenal pheochromocytoma. Neuroendocrine cells, that is pancreatic beta cells, Enterochromaffin cells share a common biologic function through amine precursor uptake decarboxylase APUD. Despite differences in embryogenic origin, anatomic site, secretory products, that is chromogranin A, neuron specific enolase NSE, synaptophysin, serotonin, histamine, calcitonin, treatment surgical resection, somatostatin analog. Okay. Next, neuroblastoma. Most common tumor of adrenal medulla in children, usually less than 4 years old, originate from neural crushed cells, occurs anywhere along the sympathetic chain. Most common presentation is abdominal distension and a firm irregular mass that can cross the midline versus Wilms tumor, which is smooth and unilateral, less likely to develop hypertension than pheochromocytoma. Neuroblastoma is normotensive, can also present with opsoclonus myoclonus syndrome, dancing eyes, dancing feet, increased HVA and VMA, catecholamine metabolites in urine, Homer right rosettes, neuroblasts surrounding a central area of neuropil, image A, characteristic of neuroblastoma, medulloblastoma, Bomsin and NSE positive, associated with amplification of NMIC oncogene. Okay. Neuroblastoma. Okay, now pheochromocytoma. Etiology: most common tumor of adrenal medulla in adults. Black arrow, a red arrow points to bone metastasis derived from chromaffin cells arise from neural crust, may associated with germline mutations, that is NF1 VHL RET main 2A, 2B. Rule of 10: 10% malignant, 10% bilateral, 10% extraadrenal, that is bladder wall organ of Zucker candle, 10% calcified, 10% kids. Okay. Red arrow points to bone metastasis derived from chromaffin cells, arises from neural crust. Okay. Symptoms of pheochromocytoma: most tumors secrete epinephrine, norepinephrine, dopamine, which can cause episodic hypertension. May also secrete EPO, leads to polycythemia. Symptoms occur in spells, relapse and remit. Episodic hyperadrenergic symptoms: 5 P's: pressure, increased blood pressure, pain, headache, perspiration, palpitations, tachycardia, and pallor. Findings: increased catecholamines and metanephrines, that is homovanillic acid, vinyl mandelic acid in urine and plasma. Increased catecholamines and metanephrines, that is homovanillic acid, vinyl mandelic acid in urine and plasma. Increased catecholamines and metanephrines, that is homovalenic acid and vanillylmandelic acid in urine and plasma. Chromogranin, synaptophysin and NSE positive. Treatment: irreversible alpha antagonist, that is phenoxybenzamine followed by beta blockers prior to tumor resection. Alpha blockade must be achieved before giving beta blockers to avoid hypertensive crisis. A before B. Treatment: irreversible alpha antagonist. That is phenoxybenzamine followed by beta blocker. Prior to tumor resection, alpha blockade must be achieved before giving beta blockers to avoid hypertensive crisis. A before B. Okay, phenoxybenzamine for pheochromocytoma. Multiple endocrine neoplasms. Multiple endocrine neoplasias. All men syndrome have autosomal dominant inheritance. The X-men are dominant over villains. Subtype and characteristics: men 1 pituitary tumors, prolactin or growth hormone. Okay. Pancreatic endocrine tumors, Zollinger-Ellison syndrome, insulinomas, bipomas, glucogonomas, rare. Parathyroid adenomas associated with mutation of MEN1 tumor suppressor codes for menin, chromosome 11, angiofibromas, collagenomas, meningiomas. Okay. Men 2A, parathyroid hyperplasia. Medullary thyroid carcinoma, neoplasm of parafollicular C cells. Secretes calcitonin. Prophylactic thyroidectomy required. Pheochromocytoma secretes catecholamines associated with mutation in RET. Proto-oncogene codes for receptor tyrosine kinase. Chromosome 10. Sorry. Men 2B, medullary thyroid carcinoma, pheochromocytoma, mucosal neuromas. A, oral intestinal ganglioneuromatosis associated with marfanoid habitus, mutation in RET gene. Men 1 is equal to 3 P's. Pituitary, pancreas, parathyroid. Men 2A is equal to 2 P's. Medullary thyroid carcinoma, pheochromocytoma. Men 2 is equal to 1 P, 2 M's. Mucosal neuromas. Okay, men 1A 3 P's, men 2A 2 P's. Men 2B 1 P 2 M's. Okay. Now Yes, pancreatic islets, islets, pancreatic islets cells tumors. This is going to be our last topic for today. Not today, for we don't know are we going to do second session today or not. So for this session, this topic is going to be last. This page is going to be last basically. Tumor of pancreatic beta cells leads to overproduction of insulin, insulinoma. Hypoglycemia leads to hypoglycemia, may seen in Whipple triad, low blood glucose, symptoms of hypoglycemia, lethargy, syncope, diplopia, and resolution of symptoms after normalization of plasma glucose level. Symptomatic patients have decreased blood glucose, increased C-peptide level versus exogenous insulin use. Approximately 10% of cases associated with MEN1 syndrome. Treatment: surgical resection. Glucagonoma, tumor cells of pancreatic alpha cells leads to overproduction of glucagon. Present with 6 days dermatitis, necrolytic migratory erythema, diabetes, hyperglycemia, dermatitis, necrolytic migratory erythema, diabetes, hyperglycemia, DVT, declining weight, depression, diarrhea. Treatment: octreotide. Treatment include octreotide. Okay. Next, and surgical resection. Somatostatinoma, tumors of pancreatic delta cells. Overproduction of somatostatin leads to decreased secretion of secretin. Cholecystokinin, glucagon, insulin, gastrin, gastric inhibitory peptide may present with diabetes/glucose intolerance, steatorrhea, gallstone, achlorhydria. Treatment: surgical resection, somatostatin analogs, that is octreotide, for symptom control. Okay, somatostatinoma, tumor cells of pancreatic delta cells, overproduction of somatostatin, decreased secretion of secretin. Somatostatinoma, tumors of pancreatic delta cell, overproduction of somatostatin, decreased secretion of secretin. Cholecystokinin, glucagon, insulin, gastrin, gastric inhibitory peptide may present with diabetes/glucose intolerance, steatorrhea, gallstones, achlorhydria. Treatment: surgical resection, somatostatin analog, octreotide, for symptom control. Carcinoid tumor, seen in image A. Carcinoid tumors arises from neuroendocrine cells, most commonly in intestine or lung. Neuroendocrine cells secrete 5-HTs, which undergoes hepatic first pass metabolism and enzymatic breakdown by MAO in the lung. If 5-HTs reaches the systemic circulation, that is after liver metastasis, carcinoid tumor may present with carcinoid syndrome, episodic flushing, diarrhea, wheezing, right-sided vascular heart disease, tricuspid regurgitation, pulmonic stenosis, niacin deficiency, pellagra, increased urinary 5-HIAA. Histology: rosettes A, chromogranin A present, synaptophysin present. Treatment: surgical resection, somatostatin analog, that is octreotide, or tryptophan hydroxylase inhibitor, that is telotristat for symptom control. Rules of thirds: 1 by 3 metastasize, 1 by 3 present with secondary malignancy, 1 by 1/3 are multiple. Okay. Carcinoid tumor arises from neuroendocrine cells, most commonly in intestine or lung. Neuroendocrine cells secrete 5-HTs, which undergoes first hepatic first metabolism and enzymatic breakdown by MAO in the lung. If 5-HT reaches systemic circulation, that is after liver metastasis, carcinoid syndrome may present with carcinoid tumor may present with carcinoid syndrome, that is episodic flushing, diarrhea, wheezing, right-sided valvular heart disease, tricuspid regurgitation, pulmonary stenosis, niacin deficiency, which is pellagra, increases urinary 5-HIAA. Histology: rosettes A, you can see rosettes here, chromogranin A positive, synaptophysin positive. Treatment: surgical resection, somatostatin analog, that is octreotide, or tryptophan hydroxylase inhibitor, that is telotristat for symptom control. Rule of thirds: 1 by 3 metastasize, 1 by 3 presents with second malignancy, 1 by 3 are multiple. Zollinger-Ellison syndrome: gastrin secreting tumor, gastrinoma of duodenum or pancreas. Acid hypersecretion causes recurrent ulcer in duodenum and jejunum. Presents with abdominal pain, peptic ulcer disease, distal ulcers. Diarrhea, malabsorption, positive secretin stimulation test increases gastrin levels after administration of secretin, which normally inhibits gastrin release, may be associated with MEN1. Okay. Last one is Zollinger-Ellison syndrome, gastrin secreting tumor or gastrinoma of duodenum or pancreas. Acid hypersecretion causes recurrent ulcers in duodenum and jejunum. Presents with abdominal pain, that is peptic ulcer disease, distal ulcers. Diarrhea, malabsorption, positive secretin stimulation test increase gastrin levels after administration of secretin, which normally inhibit gastrin release, may be associated with MEN1. Last 1 minute left and we are going to end this session. So let's see what we have read in this session. We started reading we started from Nielsen syndrome, adrenal insufficiency. We also read hyperaldosteronism, neuroendocrine tumors, neuroblastoma, pheochromocytoma, multiple endocrine neoplasms, neoplasias, pancreatic islet cell tumors, carcinoid tumors, Zollinger-Ellison syndrome. So that's it for this session. See you all in the next session. Sunday morning done right. We started our day with reading USMLE first aid. Let's do more on this Sunday. So see you all in the next session.